Okay, good morning, everyone. Thanks for coming here this morning. I'm going to be talking a little bit about vestibular testing. It's a talk I give every couple years or so, just as a refresher. There's an extraordinary amount that changes in testing, although more recently there's been video head impulse testing, and VEMP's been around, but I haven't really spoken about it in previous talks. Just on my first slide, this is the skyline of Seoul, Korea. The reason I show that is because this year's Baronnet Society meeting is in Korea in June, so I'll be going there. And it's an international meeting where they talk about the latest and greatest in vestibular testing and vestibular diagnoses. It's international, and so it's in places like Sweden, Argentina. So if you ever get a chance, I haven't been there yet, but I've heard that it's a good meeting to attend. So just in general, why is this topic important, or why is dizziness vestibular important? So this is just a graph from the US Census Bureau, and what it shows is the population that's 65 years and older as graded by total in terms of millions and even percentage. And the only thing to take away from this is that you can clearly see that the percentage of individuals 65 and older have been increasing 2010. It's only projected that this will continue to increase by 2030, almost double to 71 million individuals. Now, the reason that's so relevant is because we know that dizziness, just in general, affects greater than 50% of the population over 65, and it's estimated to be one of the most frequent reasons for medical consultation after the age of 75. So if you feel like already you have a lot of dizzy patients in your clinics, it'll probably only increase, especially for those who are going into practice in a couple years. I'm sure you all know that history is one of the most important things for any patient with balance or dizziness disorder, and it's complicated because some patients are very nonspecific in the way they describe their symptoms. One of the main reasons for that is just because it's very difficult to describe something that is not necessarily something you experience on an everyday basis. It can be non-physiologic. And of course, we break it down into three categories: vertigo, where there's actually an illusion of movement, things moving around; disequilibrium, which can be rocking, imbalance; and then finally lightheadedness or actual syncope where patients are passing out. This is just a picture that shows something that a patient might describe in a subway or a large area where they feel visually overwhelmed by lights, by people moving around. That would be something that would be characteristic of visual vertigo or visual dependence. This is just a little video of what somebody might experience, a type of symptom. Somebody comes to you and says they have the shaky camera effect. You can see that in this video, they're just walking through a cafeteria, driving down the street. Of course, that's classic for bilateral vestibular hypofunction, but that's just an example of the types of descriptions a patient might give just in terms of their balance symptoms. So the objectives of this talk include talking about bedside vestibular testing. So I'm just going to briefly review what you would see with spontaneous nystagmus and positional testing, some of the basic tests that you may do, particularly the head impulse test, and then, of course, the Fukuda stepping test and the Romberg test. And then the second part of the talk will be where more of the meat is, where I'll be talking about a vestibular test battery, reviewing some of the video nystagmography, caloric testing, rotary chair testing, and then, of course, some of the newer types of testing, which include video head impulse testing, and then the vestibular evoked myogenic potentials, or VEMP, cervical and ocular. It's going to be a lot of material and potentially fairly dense, so hopefully we'll keep your attention through it. So first we'll talk about bedside tests of vestibular function, and one of the things that I'm sure most of you have seen is that in my clinic I use video nystagmography goggles, infrared goggles that are connected to a DVD recorder and a screen behind me, behind the patient. And the reason that's important is just because it eliminates fixation, and so while somebody may not exhibit nystagmus when they're able to fixate or focus on an object, oftentimes you can uncover nystagmus by putting them in the dark. And this is an example of another setup, Fresnel glasses, where the eyes are magnified, but the patient is not able to fixate. So it's important that if you want to investigate nystagmus in particular, that you have something that can eliminate fixation. So spontaneous nystagmus and positional testing. So of course we know that with spontaneous nystagmus, one of the types of nystagmus that you can see would be characterized as a jerk nystagmus, where there's a slow phase and a fast phase, drifting slowly to the left, jerking quickly to the right. The convention is to describe nystagmus by the fast phase, so of course this one would be considered right-beating nystagmus. And at least with peripheral nystagmus, the direction is fixed, so it tends to be one side, and oftentimes it is horizontal. The convention, of course, is fast cows, cold opposite, warm same. So the fast phase, when you have a cold lesion or a hypofunction, goes in the opposite direction. So the eyes slowly, so suppose my right ear is the hypofunctional ear, the eyes drift slowly to the right and then jerk quickly to the left, and warm same. A hyperfunctioning lesion, like say somebody who's in active Meniere's, it would be the opposite direction. So as I was hinting to, peripheral nystagmus is seen in these peripheral types of disorders, vestibular neuritis, Meniere's disease. Central nystagmus usually has other characteristics such as vertical or direction-changing nystagmus. And when we go to the VNG portion of the talk, we'll just see some tracings of central and peripheral nystagmus. Now, positional nystagmus is something that we're all familiar with, most classically seen with posterior canal BPPV. About 90% of cases of BPPV are posterior canal. This is just a photograph I took of the poster that's in my clinic room. I use it to describe BPPV occurring in the posterior canal, coming from otoliths that are coming out of the utricle. It has particular characteristics, which is a latency. So there's a slight delay before you actually see the nystagmus, because there is some viscosity to the endolymph. So it takes a little while for the otoliths to be pulled down by gravity, and then the duration is typically less than 30 seconds, more in the realm of 10 to 20 seconds, just because that's the fixed distance it takes for the otoliths to move down. This is just a video that shows what you might see with posterior BPPV, but I picked kind of a more of a unique video so you could cover a couple things at once. So this is a patient that I lie her back in the Dix-Hallpike to the right. She has right posterior BPPV. You see the torsion to the right side, the upbeating nystagmus. And so she's one that I did the Epley maneuver on. Now, most of these patients I actually recheck just to make sure. And in this particular case, she developed something called a lateral canal conversion. So this is just minutes later. And you can see that the nystagmus changes, and it becomes a right-beating nystagmus. I don't know if any of you have seen that in your clinic, or if you repeatedly lie someone down, but that's usually why I tell people, if they do home epley, just to do it once a day. And the whole theory behind lateral canal conversion is that if this is the posterior canal and the otolith debris initially is here, after you do the Dix-Hallpike maneuver, you can just imagine that it goes back into the utricle. Well, in an estimated about 15% of individuals, when you lie them back down in the Dix-Hallpike to the right, the debris can actually slip into the horizontal canal, and then they develop a different type of nystagmus, and it's usually a more intense sensation. And so if you ever try the Dix-Hallpike again, if you ever do it 2 or 3 times, and notice one of the times the patient starts to develop vertigo that's different or more intense, or you're looking at their eyes and there's horizontal nystagmus, what you want to do is quickly turn them over to the other side, sit them up, and just stop what you're doing, because when you turn them back to the other side, there's a chance that as the particle is starting to go down, you turn them back and it'll go back into the utricle. If you wait too long, it might actually sink all the way down the arm, and then you have to do a formal log roll maneuver or some other treatment to fix them.
How do you account for the fact that sometimes when you sit them back up, they get very vertiginous?
Yeah, that's a very good question. So it can be one of 2 things. Once again, that's where the goggles might be helpful, because number one, some patients, as the otoliths are settling down into the utricle, can have some imbalanced sensation. That's fairly typical right after the repositioning or for the full day afterwards. And then the other potential cause is that the otoliths are actually falling back down into the posterior canal. And usually, if you have the goggles on, you can see the nystagmus reversing. And so I would say it's one of those two situations that would be causing that. As far as the anatomy and physiology of, this is right posterior canal BPPV, we know that the posterior canal is linked to pairs of extraocular muscles. And so the right posterior canal in dark is neurologically connected to the inferior rectus and the superior oblique. And so that goes along with a slow phase. So you lie someone on the Dix-Hall pike to the right, their eyes slowly go down and go against gravity because they're lying this way. So it goes like this, and then it springs back. And so that's why, since we have the convention of fast phase, that's why you end up seeing the upward and torsional. And so this is an example, another example. And so patient Dix-Hall pike to the right, and you see the slow phase is actually down. It's hard to see, and inward. And then the fast phase jerking back is what we see as convention. So there is a direct correlate to the extraocular eye muscles. Epley is something that you can even do in an exam chair. I often, if I want to save time or save expense for the patient, I often just do it in the exam chair. It can lie flat. You can put the headrest back, and I've done a lot of successful Epleys in just the exam chair. You don't necessarily need to be at their head. You can just do it at their side. I get a fairly good visualization of their eyes, and it's efficient. It's just using your existing equipment. Now, the next test that you may do at bedside is the head impulse test and dynamic visual acuity. Now, when you talk about those tests, you have to talk about the vestibulo-ocular reflex in general. Now, the vestibulo-ocular reflex, one of the main roles is to maintain vision on the fovea, which is this very small area, during motion, because that's where you have the greatest density of photoreceptors. It's estimated that visual acuity declines up to 50% when objects are 2 degrees off from the center of the fovea. So that's one of the main functions of the vestibular balance system, is to keep objects focused, in focus. How the VOR works? Well, as I mentioned earlier, the VOR works on all 3 eye muscle pairs. And just for sake of illustration, we'll talk about the horizontal or lateral semicircular canals, since that's the easiest to think of conceptually and to diagram. So we see here that the left horizontal canal is coupled with the left medial rectus and the right lateral rectus. This is just an example of some of the pathways, ipsilateral, contralateral. So when you turn your head to the left, this excites the left horizontal semicircular canal because the endolymph is moving. It's not well diagrammed here, but it's moving towards the cupula, so it's ambulopedal. And so this, in effect, excites the left semicircular canal, but then it's the opposite direction on the right, so inhibits the right semicircular canal. And because the left canal is tied in with the medial rectus and the lateral rectus, that's why you have the eyes moving to the right. Now, with a lot of the quantitative vestibular testing, there's a measure called gain, which is a ratio of the of the head movement to the eye movement, and we'll talk about that more in detail. But essentially, you would imagine that with an intact vestibulo-ocular reflex, the gain would be about 1. In other words, you move your head this much, the eyes would move in an equal and opposite direction so that you keep things stable in your gaze. Head impulse test, I'm sure many of you have done it in clinic. Patient is moved, the head is moved very quickly with their eyes fixated on a target, usually your nose, especially if they're in front of you. This is an example of what it would look like with a normal head impulse test. Jerking their head quickly to the left, you see they're able to keep their eyes focused on your nose. Typically in somebody with hypofunction, particularly if it's not compensated, you turn their head, they're not able to keep their eyes focused on your nose, and then you see a quick catch-up saccade, and so there's a lack of smooth VOR. One note about catch-up saccades is later on when we talk about the video head impulse testing, there are 2 different types of saccades. There are overt and there are covert saccades. The overt saccades are like these, where you'll actually see them. They're overt, they're obvious. The covert ones are ones you aren't able to see because they may occur while the head is turning, and we'll see examples of what that might look like on a particular tracing. This is just from Balance Function Assessment and Management book, but this is an example of kind of the speed with which you might do that. Of course, the examiner in this case is behind the patient, so this is more of a setup you might do for the video head impulse test. They were starting to do the lateral canals, but the vertical canals, but there's actually a better way to do it rather than twisting somebody's neck. Somebody with a unilateral weakness has a high likelihood of a positive test, about 40 to 60%. The specificity is very high, so if you see this slippage of the eyes and the overt saccade, high likelihood that they have a hypofunction on that affected side. Sensitivity is not so great, one of the main reasons being many times these patients may have covert saccades that you're not able to see but still represent a weakness. Dynamic visual acuity is a check, a visual acuity check as you look at an eye chart while the head is oscillated at 2 hertz. And so as an example, it's 1, 1,000, 2, 1,000, 3, 1,000. And that speed in particular is very important because if you go slower than that, then the smooth pursuit can actually help to stabilize the vision. Normal function is about a 1 to 2 line drop in visual acuity because as you're moving your head back and forth, you do get a little slippage off the fovea. Nobody's perfect. However, someone with bilateral hypofunction may have as much as a 5 line drop in visual acuity. Unilateral may be somewhere in between, and I see some of you guys kind of testing on that chart. I don't know if any of you have some hypofunction or problems. Sensitivity and
How do you tell which ear?
Oh, that's actually a good question. You can't. That doesn't really give you side just because you're doing it on both sides, and
Or the head impulse.
The head impulse test. So if you when you think conceptually about the lateral canals, you can think of them as this example. If my fists are the cupula, then the arms are the canal itself with the endolymph, and movement that goes towards the cupula is excitatory. So when you move someone's head to the left, inertia is going to cause it to push against the cupula, so that's the left side and the right side. And typically, if it's a unilateral hypofunction, when you move them towards that affected side, that's where the eyes will slip. Bilateral, actually I had a lady the other day with bilateral hypofunction, you'll see it on both sides. Yeah.
So toward the side of the weakness.
Towards the side of the weakness. So you do acoustic neuroma surgery on the left, gamma knife, you turn them towards their head towards that side. If they're not compensated, you would expect to see some level of slippage. So the dynamic visual acuity actually has a very high sensitivity and specificity. Unfortunately, it's not something that I regularly do in clinic. It does take some time, and you have to have a room set up. I mean, it's not that complicated. I know physical therapists, though, do it a lot, but it can be a very effective test. And then finally, to round out the bedside testing, I have the Fukuda stepping test and the Romberg. These test the vestibulospinal reflex, and this is an example of some ultimate fighters who obviously need to have very intact vestibulospinal reflex. That is formed by a synapse of the vestibular neurons, the spinal motor neurons, and the saccule and utricle play a very important role in this reflex. So the Fukuda stepping test is a direct assessment of the vestibulospinal reflex. I'm sure many of you have done it. This is just an example of the positioning. An abnormal result is after 50 steps that there's more of a greater than 45-degree angle of rotation, and it's generally towards the side of the lesion. And once again, this is from that book. So this is an example of somebody who might be doing the Fukuda stepping test, and potentially, in this case, you can see he's drifting over to the left side. So we would possibly imagine that he would have a left peripheral lesion that may not be fully compensated. However, it has a fairly poor sensitivity and specificity. Sensitivity is about 70%, specificity about 59%. So it's probably a test that's best used in addition to other tests. In and of itself may not be as helpful. The Romberg.
For the Fukuda, could it be an excitatory lesion
Yeah, it could be an excitatory lesion on the opposite side. Essentially, that's a good point. For the Romberg test, it's actually not a test of the vestibulospinal reflex. It's not a peripheral test. It assesses the dorsal column of the spinal cord. It attests for sway, feet side by side or tandem. I'm sure all of you have done the Romberg test. And essentially, you're looking for increased sway when they close their eyes, they don't have visual input, versus when they have the input. And dorsal column damage is definitely one of the common causes seen in tabes dorsalis, or vitamin B12 deficiency. A lot of my elderly patients who complain more of an imbalanced sensation definitely check a vitamin B12 level. I know a lot of primary care doctors do that. And then, of course, you can see it in peripheral neuropathies, cerebellar lesions. So it's fairly nonspecific, but it's a good general assessment of postural control. So now we'll get into the meat of the talk, the second half, where I'll be talking about vestibular test battery. This is an example of a rotary chair, all set up, strapped in. Fortunately, we don't have that here, but I know that's the big layout, and it takes resources to maintain. So in general, main question is, why do you perform vestibular testing? So of course, when you see the patient in clinic, the diagnosis is still in question. When you know there's an existing lesion, but you're not clear how well compensated somebody is, or finally, prior to a otologic surgery intervention. And of course, we get VNGs, calorics specifically for patients who get acoustic neuromas, resected, or cochlear implants, all very great indications. Now, the main goals are, of course, to try to localize a lesion, usually to one side or the other, and then assess degree of compensation to an existing vestibular deficit. But what it does not do, it actually doesn't measure disability from vestibular deficit. So if you ever get patients looking for disability, you may find it on the exam, but disability, of course, is very subjective, and every patient is different how disabled they are. And then this is from an old slide. It doesn't assess vertical semicircular canals except for video head impulse testing, and we'll talk a little more in detail about how you might position a patient to assess the vertical canals. So now with the video head impulse testing, that's potentially available. So this is some of the main parts of the vestibular test battery. Of course, it's by no means exhaustive, but for the VNG portion, there's an oculomotor portion, spontaneous gaze-evoked nystagmus. We already kind of talked some about that. Positional testing. And then you have the quantitative tests, which we'll talk about in a little more detail. The caloric test, rotary chair test, video head impulse test, and then the two varieties of VEMP. So whenever you do a VNG test, you want to start with oculomotor testing, because if the eyes are not tracking, if there's something wrong with the eyes, it's very hard to pick up accurate nystagmus. Oculomotor abnormalities are usually obvious and recurrent. So for example, if someone has a pursuit problem, they're following your fingers, but they have the saccadic breakup of pursuit, you'll usually see it with problems with fixation on calorics. You'll see it problems with OKN, just because there's a lot of central redundancy in the brain, vestibular nucleus area between all these different tests. So for example, you do a VNG and just the pursuit is a little bit off, but everything else is fine. Chances are patient may not have been paying attention on that part of the test, and it's probably not a clinically significant finding. For those of you who have been in the VNG room, this is just an example of what a random saccade paradigm. Essentially, they're just following the light bar, going right and left, different distances, kind of unpredictable. And we'll see what a tracing of that might look like. And then the next paradigm they're going to show is smooth pursuit, which is essentially something you can do in the office, just going back and forth. Saccades are very important. We already sort of talked about saccades already in the context of a uncompensated lesion turning somebody's head, catch-up saccade. But it's a very fast eye movement with the goal of bringing objects onto the fovea. Clear focus, clear vision is, of course, key when you talk about the vestibular system. It's very robust with a central redundancy. In other words, even as somebody gets older, usually the saccades will be intact. Now, of course, cases where it's not are things like alcohol abuse, alcohol dependence, things like that, which is why it's often used. Pursuit is used with sobriety testing, but yeah, so saccades are generally intact. An example of abnormal saccades, so we'll see as a convention that whenever the target goes up, that's right. We're upright individuals, upright human beings, so it's going to the right, some pause, left, right, left, right, left. And this is the right eye and the left eye. So this is an example of what an abnormal saccade on test would look like. It's usually very obvious. Essentially, you can see that the shape of the eye movements is not really greatly correlating with the actual target.
What does that tell you?
Oh, that just tells us that there's something central going on. It doesn't really specifically localize. This is an example of one of the classic types of saccades, internuclear ophthalmoplegia. It just means the left eye will not go beyond midline. It will not adduct. And then the right eye, when it abducts, actually has a little saccade backwards. This is something that, this is sort of the classic type of finding you might see with saccade testing. I've seen it once. It was kind of interesting because this patient was said to have a lazy eye, but actually if you looked at their eye movements, they actually had a internuclear ophthalmoplegia. It's something you can see after stroke or multiple sclerosis. Those are the two, I guess, most classic times you'll see these. Sometimes it can be related to drug toxicity, but it's probably one of the few very distinctive findings you'll see on saccade that may be more localizing for the lesion. Pursuit, corollary to saccade, it's a smooth eye movement to bring an object onto the fovea. The movements are typically under 2 Hertz. That's why for the dynamic visual acuity test, you need to do it at 2 Hertz or greater, because if you go slower, you'll be engaging the pursuit system. It's not a robust system, so it's affected by age or medications. And typically, if there's a problem, it's a saccadic breakup of pursuit. So the saccades try to take over for the lack of pursuit. That's why many policemen use this for sobriety testing, because something like alcohol intoxication would show a lack of smooth pursuit. This is just an example going to the right, to the left, and then at different speeds. That's smooth pursuit. For saccadic breakup of pursuit, you see, the really jerky saccades. And so this is an example of what you might see in the eye movements of someone who has alcohol abuse. I mean, I think it's fairly subtle, but you can see that as they're pursuing, there's just that slight little jerk back and forth. And that's a very clear central sign. That can be age-related, so you see somebody who's 85, 90, 95, they may have some level of saccadic breakup of pursuit, but often can be seen with drug intoxication, other influences affecting the central nervous system. So next part of the vestibular test battery is the spontaneous and gaze-evoked nystagmus and the positional testing. Now, we already talked a little bit about that in the bedside testing. This is different in that you'll be using goggles, and the computer will actually be measuring the slow phase eye speed. So this is an example of the type of tracing you might see for nystagmus. This is the horizontal channel, the vertical channel. But since nystagmus, the convention is a fast phase, the fast phase has a greater slope, so you see going up, right, and so it's measured by the, I'm sorry, so upright, and then the other direction has a lesser slope. So the right, this is called right beating 11, and this is an example of what you might see with the eye in somebody who has this sort of pattern to their nystagmus. This is just some examples of what you might see with direction-changing nystagmus. So this is, my laser pointer is kind of dying on me. So this is what you might see in center gaze if somebody's fixating. So you can see that the greater slope is downward, so this is left beating, and then when you take away the fixation, it actually becomes right beating. So that would obviously be a very central sign. Another example of gaze-evoked nystagmus, so you have center gaze, really no nystagmus there. When they look to the right, a pretty significant right beating nystagmus. Once again, central sign that you would see. And then finally, an example of failure of fixation suppression. So spontaneous nystagmus, it says no fixation, kind of bumpy pattern, but you can see clear sawtooth pattern of nystagmus when there is fixation. So those are just some examples of what you might see on the actual test tracing when you're recording it. So the final portion of the talk, we'll be talking about the quantitative tests, where you can actually measure the degree of weakness, potentially assess the side of the lesion, caloric testing, rotary chair testing, video head impulse testing. Sorry, actually, the VEMP is not really quantitative, but it just is towards the end of my talk. So caloric testing is one of the tests that Bernet got the Nobel Prize for, and so he has that conference in honor with his name on it, which will be in Seoul, Korea. Described by Bernet way back in 1906. So we're using tests that the concepts originated more than 100 years ago. It's a test that that localizes unilateral hypofunction, but it's only a screening test for bilateral hypofunction. And that's always really key to remember, because you have somebody who has no caloric function. That may hint at bilateral vestibular hypofunction, but it's not the gold standard. The gold standard is a rotary chair test, and we'll talk about why that is. I'm sure many of you have seen the procedure. It's done with the subject's head inclined 30 degrees, just because the horizontal canals are slightly tilted upwards. So 30 degrees puts these canals more in line with gravity. And you apply warm or cold water, some examples there. If you happen to use air, which is a reasonable substitute in most cases, the temperature, of course, goes higher for the hot air, colder for the cooler air, because air doesn't conduct temperature as well. And then you use ice water if there's no nystagmus to put a very strong stimulus. So I was talking about the caloric test. Now, the next slides will actually be talking about some of the tracings that you would expect to see with caloric testing. One of the key things about caloric testing is that when you put the water in the ear, you won't immediately see the nystagmus. There's usually a little bit of a delay. I guess it takes some time for the temperature to change in the middle ear space area. And so there's about a 15 or 20 second delay before you start to see the nystagmus. The nystagmus follows the convention that we discussed, the cold opposite, the warm same. And then usually the nystagmus, as it's building up, peaks about 30 seconds after it starts moving, or 60 seconds after the irrigation starts. With unilateral caloric nystagmus, okay, so it's restarting. With now one of the earlier things I talked about is with caloric testing, you can localize a lesion, you can localize a unilateral lesion. However, it's only a screening test for bilateral hypofunction. And the main reason for that is because the caloric test only tests for a very slow VOR response. In other words, the equivalent VOR response or head movement response for a caloric test is 1 cycle every 5.5 minutes. And so if you imagine someone sitting in a chair and moving 1 cycle back and forth in 5.5 minutes, that's the equivalent speed of caloric test. That's the equivalent VOR speed that it's assessing. So you can clearly see that that's non-physiologic. Furthermore, when you have any weaknesses, it's most likely that the lower frequency head movement, the lower frequency gains will be first affected. And so that's why the caloric test will be first to be affected with bilateral hypofunction, but that doesn't necessarily mean that the more physiologic head movement speeds will be affected. That's why we have the rotary chair testing and we have the video head impulse testing in order to rotary chair testing and video head impulse testing in order to assess the more physiologic head movements gains. So, okay, so it's just going to configure a little bit more. As far as the caloric testing, there are some limitations when you're doing caloric testing. First, there are some anatomic limitations, because as I was discussing, that temperature, whether warm and cool water, needs to be conducted to the inner ear. And so there may be conductivity problems. If there's wax in the ear, if the ear canal is exceptionally small, if there's obviously, you know, if the bones are different between sides, you may have different caloric test results. Also, caloric testing is not really calibrated. In other words, you can't use absolute value of eye speeds. And so, for example, somebody has an eye speed response on one side of 20 degrees per second, another person has 50 degrees per second. The absolute value doesn't matter. What you're looking for is the relative difference between the ears. That's usually the key for the caloric testing. The other thing that's important about caloric or even rotary chair testing is that the state of mind of the patient can make a significant difference. In other words, if somebody, let me just put in my password. You have to make sure someone isn't too sleepy, someone isn't too anxious, because that can definitely affect the results of the testing. That's why often when you're doing caloric testing, you want to do tasking, ask them to repeat the states or focus on certain names so that they don't try to consciously suppress their eye movement, because patients are able to actually suppress their nystagmus and eye movement. And definitely if they feel anxious, nervous, I mean, those are all things that will affect the caloric testing. Well, first, the head impulse test is at more physiologic speeds, and so you would expect that there would be some abnormality there. And then in my clinic room, I use the video nystagmography goggles, and I slowly move their head back and forth at more physiologic speeds. And for people where they don't have bilateral hypofunction, there will be some slippage. I mean, it's kind of like a cheap rotary chair test. But someone with bilateral hypofunction, their eyes actually will not drift. I mean, it'll just be like, you know, just moving their head back and forth. So,
A comment about the calorics is if they have a cavity, mastoid cavity
oh, yeah.
on one side, it's not even worth doing it because you're going to
yeah. I mean, you can assess if there's function, but yeah, I mean, there's no way to compare the sides because it's very different. So one of the things that I mentioned earlier is that the measurements of VOR, you can measure it at 3 different levels. One is very slow, calorics, 0.003 hertz, equivalent to 1 cycle every 5.5 minutes. Rotary chair test, which we'll be talking about next, is in the middle. And then finally, the vestibular auto rotation test, video head impulse test, is more of the physiologic gains. So the rotary chair testing is one of the tests where it's more of a natural stimulus. In other words, the patient is moving back and forth in the chair. It's limited by only testing the horizontal semicircular canals, but it is the most reliable index and considered the gold standard for testing bilateral vestibular hypofunction. The practical range of frequencies that can be tested are 0.05 to 0.5 hertz, just because if you go a lot faster, the patient's head is jarred too much. And generally, you use a sinusoidal acceleration going back and forth, and the patient is in the dark to eliminate fixation. So patients are put in this booth, the door is closed, so it may be difficult with claustrophobic individuals. One of the main things that it assesses is something we hinted at earlier, which is gain, the ratio of the head movement to the eye movement. Of course, with an intact vestibulo-ocular reflex, you would expect a gain of 1. As the head is moving to one side, the eyes are moving in an equal and opposite direction to keep the fovea fixated on the object. Bilateral hypofunction is plus minus 2 standard deviations below normal. The normal, which is just taken from a population, is in blue. This is an example of what you might see with vestibular hypofunction, bilateral hypofunction. There's an artifact where you can see that there's higher gains at higher frequencies, but that's thought to be more related to engaging some of the other compensatory mechanisms.
For unilateral, in that case, would it be just like 50%?
Yeah, so unilateral, a lot of times, if it's uncompensated, you'll see that it's about, yeah, as you said, 50%, because what they're doing when they're measuring gain is they're averaging the movements back and forth. So suppose you have a left unilateral weakness. Well, of course, to that side, you'll have low gain, but then the right will be normal, so it'll be averaged somewhere in between. Of course, if someone has already compensated from that unilateral weakness, the gain will actually be within the normal range. So this is that other slide that I was discussing, once again showing bilateral hypofunction way below the normal area. The head movement tests that are more physiologic include the vestibular auto rotation test or video head impulse test. This is just an example of what the vestibular auto rotation test might look like. So no goggles, but little electrodes to look at the eye. So essentially the patient hears a tone, focuses on the target, moves their head back and forth. This is not as popular. I mean, it was described several years ago, but I guess it's just not as much utility, probably because it's hard to localize the side of the lesion. You can see that person is not really even keeping up with that movement. So then the final two tests are we could consider relatively newer tests, video head impulse testing, and Dr. Derryberry actually mentioned she recently went to an international Meniere's meeting, and that's all they talked about, video head impulse testing, and I'm sure in Seoul, Korea, that's what they'll be talking about as well. And then VEMP testing, which has been around, but I haven't used it as much, but it can definitely have utility. So the video head impulse test is, of course, a way to quantitatively measure the head impulse test, and it uses video goggles. And just as an example, the head impulse test, something like that, and examiner behind the patient's eyes, and this is, except the patient would have goggles with the video head impulse test. This is just an example of what the setup might look like. And this is essentially the same setup as a VNG, except, so same setup in that there are these goggles. These are the little lenses that will track the eye movements. The main difference, though, is that there's this particular device that measures the head movement. And so that's the only additional attachment that you need. So if you are investing in a VNG system, adding on video head impulse test is actually not that much more. You use the existing equipment. So essentially you have the examiner behind the patient, have them fixate, and then you move their head in various directions to test the canals. Two of the important measurements, of course, include gain. As you had with the rotary chair test, the ratio of the head to the eye movement. And then the other important measurement, as I hinted at earlier, are the saccades, the catch-up saccades. For example, with this right-sided hypofunction, patient turning their head to the right, there's that catch-up saccade to the left because they're trying to stay on the target. When you can see the saccade, it's called an overt saccade. When you can't see it, it's called a covert saccade. Now, how do they know that these things exist? Well, it's because some of the testing has been done with goggles and even search coils in the past. So this is an example of overt versus covert saccades. So Weber et al., 2009, what they did is they recorded eye velocity profiles at increased head impulse test speed. So for example, this is the lower speed, increasing speeds. This is a normal subject. So what this is it's the vestibulo-ocular reflex. So as you would expect, as you go to higher speeds, you'll see that the vestibulo-ocular reflex increases because it needs to have more gain to keep the eye focused. And then these are some examples of small overt saccades. So after the head movement, you can see slight eye movements just because you may not have 100% attention. However, in a patient with vestibular neuritis, you'll see two different types of saccades. So once again, this is the VOR, smooth here. Unfortunately, this graph doesn't actually show the head movement. I have other graphs that will show the correspondence to the head movement. And you see here, once again, you see the overt saccades. So in this individual, you would probably know in clinic that they have hypofunction because you would see the obvious overt saccade. However, you can see that along with this VOR, there are these other saccades, which would be considered covert saccades. And so these are saccades that occur as the head is rotating, so you can't visually see it, but the computer can pick it up. And there's some better examples. So this is an example of a patient with an acoustic neuroma where apparently the overt saccades, which you can see here, are too small to see in the office, just because you need a certain level of eye movement to actually see. But you can see that this particular individual has pretty large covert saccades that are around the vestibulo-ocular reflex. It'll be better illustrated in these next few slides because it'll be in color. One of the key benefits of the video head impulse test, though, is that it can assess the vertical semicircular canals. And this is where it's been a pretty significant breakthrough just because all the testing I've talked about so far focuses on the lateral or horizontal canals. Now, McDougall et al., it's actually the same group from the earlier paper in 2013, found that the best way to assess the horizontal canals, for example, the right side, is to actually have the patient's head turned and their eyes looking towards the, so for example, if you want to assess the right vertical canals, superior or posterior, you turn their head to the right and have their eyes look over to the right, because when you do that, when you have their eyes looking over, you decrease the amount of torsional nystagmus, and it becomes more of a vertical nystagmus, which is a lot easier to track. So McDougall did a variety of head impulse tests in the different planes, and you can see that, and this will be the convention through the rest of these slides: right posterior, left posterior canal, left lateral, right anterior, left anterior. Nice thing about this is it's in color, it kind of shows what's going on. So the head velocity is measured in green. So you can see the green here. The VOR is in blue. The saccades are in red, so it's very obvious to see the actual saccades. This is an example of a normal patient. The gains are close to 1. So as a result, you don't really see the green as much because the blue is right on top of it. That's what an intact vestibulo-ocular reflex is supposed to be. Compare that to somebody with bilateral vestibular hypofunction with gains close to 0. You see some colors, more colors popping up. So once again, the different canals, you see all the canals are affected. So the head velocity in green, you see the blue is barely even catching up. There's no blue, no VOR, but then you see these a lot more red because there's significantly more catch-up saccades just at varying time points. So that's one extreme where there's no vestibular function on either side. How about with hypofunction? Well, this is an example of an individual with left vestibular nerve loss, looking at covert and overt saccades. So you look at the right-hand side, you don't see much of the green because the blue is overtaking it, so the gain is about 1. Not a perfect test because there's still some noise on the right posterior canal, but you can see that if you use computer programs to statistically average things out, there is a significant difference on all the left side. Now, you can pick up on covert and overt saccades on this because this is the green is the head movement, the blue is the VOR, which is slightly decreased, and then the covert saccade is the one that occurs during the head movement. And so you see as the head movement is slowing down, there's a little saccade. That's one that you may miss. And then the overt saccade, of course, occurs later on. And so this clearly shows the differences of the different types of saccades. This is an example of somebody with just right posterior canal loss. Once again, of course, there's still some noise you see, some red in the other channels, but you can see that, I mean, there's a pretty significant difference between that right posterior canal and the other canals. And once again, the green is the actual head movement. The blue is the VOR, which is decreased in that right posterior canal. The covert saccade is that red that's closest to the green, and then the overt saccades afterwards. And so this is potentially a very powerful tool to localize particular semicircular canals and assess if there's any weakness. So as I mentioned in some of the earlier slides, for measurements of VOR, you have the calorics, very slow eye speeds. You have the rotary chair test somewhere in the middle, and then you have the video head impulse test, which is much higher speeds. Out of these things, though, probably the rotary chair test is still the gold standard just because it's the most calibrated. It assesses the VOR, the gains at all these different frequencies, while the calorics and video head impulse tests are not necessarily calibrated. You get what you get. In other words, whatever response they have, they either have it or they don't. For calorics or the video head impulse test, they either have it or they don't, covert, overt saccades. So rotary chair probably has still more data in order to verify a bilateral hypofunction.
Calorics give you they localize it.
Yeah, calorics can localize. The video head impulse test can also localize. The calorics aren't great at localizing, but for someone who's not compensated, there is a measurement called asymmetry.
The rotary chair is not great.
Yeah, for localizing.
Calorics.
Yeah, calorics are great for localizing.
I want to clarify that. Yeah.
Yeah. And then finally, just a couple slides talking about VEMP, vestibular evoked myogenic potentials, an electromyographic response to an acoustic stimulation. It's an inhibitory response for cervical VEMP. That's what we'll talk about the most. And so the neck muscles need to be activated. So the typical setup, ground lead, leads on the sternocleidomastoid, where you would, and then the earplug where you would put in clicks or tones. It can be a challenging test for individuals who have difficulty lifting up their neck because they need to be lying back and slightly lift up the neck so it can be tensed because it's an inhibitory response. It takes advantage of something called the vestibulo-ocular reflex. This is just a brief description of the pathway saccule, inferior vestibular nerve, vestibular nucleus, and then down to the accessory nerve and sternocleidomastoid. The cervical VEMP is the only way to really test the inferior vestibular nerve in isolation to the other tests. Although, sorry, with the video head impulse testing, you can test the posterior canal and assess the function of the inferior vestibular nerve. And the characteristics, and some of you may actually look at this in clinic when you're trying to test for superior canal dehiscence, is what would be called a P13 wave and an N23 wave. So it's a wave that occurs at 13 milliseconds and 23 milliseconds. That's generally what you're looking for. The type of hearing loss matters, which makes sense because essentially you're trying to get sound to go into the saccule, which is right here. So you can imagine that any hearing loss after the saccule, sensory neural hearing loss, is not going to have as much of an effect, but any hearing loss before the saccule, anything conductive, will affect the individual. So even as low as a 10 to 15 decibel hearing loss can obliterate a VEMP response. Unfortunately, I don't have the audiogram to correspond to this, but this is an example where the left side has a conductive hearing loss, but the right side doesn't. And so you can see the clear signal on the right, not so much on the left. However, the VEMP can be present in a severe sensory neural hearing loss. So the left is reasonable, right is deaf. And you can see that this is the left and this is the right. So the amplitude is a little bit decreased, but you can see you get that really nice waveform, 13 seconds, 23 seconds. And so this is a good test in somebody with sensory neural hearing loss. Now, I guess the main question is it useful clinically in a variety of clinical scenarios? Superior semicircular canal dehiscence, vestibular neuritis, bilateral hypofunction, ototoxicity, gent injections, and Meniere's disease. So superior semicircular canal dehiscence, definitely yes. And this is most of the time this is most of the reason that people order this test. The third window, which occurs over the superior semicircular canal, is thought to increase sound conduction. And so what you look for are lower thresholds on the affected side. And so this is an example of what you might see on the VEMP test. Once again, you see the P13 N23 wave, and then this is for the right side, this is for the left side. These are the frequencies, 95, 80, 75, 70. Main difference is you see that the threshold, you recognize the P13 N23 wave at a much lower stimulus than on the right-hand side. So that's the side that has a superior semicircular canal dehiscence. So can be very effective for another way of diagnosing an active superior semicircular canal dehiscence. This patient may even have a conductive component to their hearing loss, like very low, below zero bone thresholds as well. So the VEMP is just a way of measuring, another way of measuring somebody with increased conduction on that affected side. Vestibular neuritis, yes, can be very helpful, especially if it's combined with calorics. Now we know that about, based on what study you're looking at, 55 to, 100% can be superior vestibular nerve. And we know that the superior vestibular nerve is not connected to the saccular posterior canal. So in this patient, you would expect a caloric weakness, superior vestibular neuritis, but then a normal VEMP signal. So that would be a good sign that it's a superior nerve that's just affected. Of course, I'm sure many of you have had patients who have the classic history of vestibular neuritis, but then they have normal caloric testing. So it's possible that they may be one of the few who have just inferior nerve involvement. Well, with the cervical VEMP, you can assess that because that individual, the VEMP will be absent. And then, of course, there are some cases where it's both the superior and inferior, and you would expect the response to be absent. Bilateral vestibular hypofunction or ototoxicity, yes, can be very effective because you'd expect the superior, inferior nerves to be affected. You're ablating all the function. And some individuals even use it to assess intratympanic gentamicin response. For Meniere's disease, you're doing IT gent. Of course, you could get a caloric test, several visits, or you could just do a cervical VEMP and do the gent until that response dies down. Cervical VEMP may be a little faster, more convenient to do than the repeat calorics.
How much hearing do you have to do the cervical VEMP?
Yeah, so as far as sensory neural hearing loss, you can be nearly deaf. Conductive hearing loss, though, if there's up to 10 to 20 decibel conductive hearing loss, that obliterates the response because the sound is not getting conducted to the saccule. So it is limited by the conductive hearing loss.
Even severe hearing loss?
Oh yeah, yeah. Someone who's severely deaf, you can even assess that.
What I'm wondering about, that we see, I'm treating a patient right now that has severe sensory nerve loss. I've given her gentamicin, and even on ice water, she has no response, but yet she's on study. So I'm wondering if she still has inferior to superior function.
And the VEMP would be a good way to test that.
But she has a severe loss.
Right, yeah.
But she could still do
Yeah, she could still potentially. So that's a possible application of the cervical VEMP. And then finally for Meniere's disease, cervical VEMP probably wouldn't be helpful. I mean, I don't know how deeply this has been studied, and the main reason is because theoretically with Meniere's disease, the saccule can go through various stages. It can be dilated at certain parts, it can be collapsed at end-stage disease, and so depending on the status of the saccule, you may have hypersensitive, increased amplitudes or decreased amplitudes, and so it's not necessarily a reliable measure. Now, of course, if you use the VEMP in addition to another way of measuring the inner ear, like a fancy MRI where you're looking at dilation, perhaps it might be more useful, but in and of itself, probably not as useful. So, a couple more slides, ocular VEMP, and then I'm finished. So ocular VEMP, I'm not going to talk in great detail, but it's an excitatory response, and once again, it's a response to sound in the ear, but it affects the utricle and the superior vestibular nerve. And what ends up happening is when the sound is put into the ear, the contralateral inferior oblique muscle moves, and so there's a little twitching of the eye. So the setup is essentially electrodes around the eye, which is probably the type of setup we used to have 20 years ago when we were just doing the ENGs, not much different. The benefit of the ocular VEMP is that it's easier to perform than the cervical VEMP. You don't need to keep the neck flexed. You just need to have someone sit there, focus on an object, trace their eye movements, and it actually may be more sensitive and specific for superior semicircular canal dehiscence in just a recent study out of Hopkins with John Carey's group. And so, this is something, I don't think we do this in our clinic, but you see the setup is not necessarily that much more difficult. You're just assessing the response of the eye muscles. So in summary...
Why not use a video goggles? Why hook up the VEMP?
That's a good question. Well, I guess you could. The problem with the video goggles is that it's not good with measuring torsion, and the inferior oblique would provide more of a torsional response, and so you would miss a lot of the signal. I mean, probably with the torsion I imagine there would be some downbeating, but that might be hard to pick up with the video goggles. But the benefit of the electrodes is you can see more of the torsion.
Well, if you're watching them, you pick it up. I mean, what you're saying is you can't make an objective recording.
Yeah.
More subjective.
Yeah, it would be more subjective. And then plus, if you're trying to measure thresholds with superior canal dehiscence, you can go down lower and lower signals, but when it's a really low signal, it might be actually hard to see, and it's only the electrodes that would pick it up. Yeah. So just kind of in summary of the last part of my talk, now we see that with the variety of testing, we can investigate most of the labyrinth, the vestibular labyrinth. Of course, we have the Calorics and Rotary chair for the horizontal canals. We have the vestibular evoked myogenic potential utricle with the ocular VEMP, saccule with the cervical VEMP, and then now with the video head impulse test, we have more information about the vertical semicircular canals. And so definitely, even though when Baronet described the caloric and rotary chair testing, that was really earth-shattering. I mean, that was pretty significant. We've definitely made some gains over the past 10 or 20 years in terms of fine-tuning some of the vestibular testing. So if you have any questions, happy to answer any questions. Any other questions?
Ice calorics.
Mm-hmm. Yeah, so I mean, ice calorics is essentially just a even strong stimulus to the ear. So the main principle, actually, yeah, and I have a slide that while my computer was rebooting, we didn't look over, but yeah. So So the mechanism of ice calorics or calorics in general is that there's a gravity-dependent response where this is the horizontal canal, this is the middle ear, the air space, and then there's bone, and then you put water in the external canal. So this 44 degrees Celsius water, which would be a warm caloric, the temperature gradient is built, and so this part has about 44 degrees, this part may be more room temperature. We know that heat rises, and so that would cause the endolymph to actually flow towards the 44 degrees, and then vice versa. If you have a cold temperature, then it's heavier, so it's going to go the opposite direction. And then, of course, if you have ice temperature, that's even more of a response. And so,
we put them prone just to get more excitatory response.
yeah, so the prone and supine, the main reason you do that is because many times when somebody has a hypofunction, they're going to have some level of spontaneous nystagmus. Usually when they have spontaneous nystagmus, it doesn't matter whether you lie them down or put them on their back. However, if you have a caloric-induced nystagmus and it's gravity dependent, then when they're on their back, it's going to go around this way. When they're prone, it's going to go the other way. Now, that being said, calorics can occur in outer space because there is a gravity-independent component, but that's estimated to be only 10% of the total response related to a direct temperature stimulation. So at least in gravity, that's not that significant of a component, which is why for the testing, yes, in order to assess whether it's actually an ice caloric response versus just spontaneous nystagmus, you lie them supine and lie them prone, because you would expect that with a caloric response, with a gravity-dependent response, turning someone over would switch the direction of the movement.
Yes.
So,
Can you use VHIT to screen for superior canal deficits because of there has to be a change of flow in superior canal.
Well, so VHIT, that's a good question. I don't know if people have really investigated that, whether it necessarily affects the gain or would cause a difference in the saccades. I mean, I guess conceivably, if there's bony covering and then one part is membranous, maybe if you move their head, it would bulge out and would cause a response. I think a lot of that probably depends on how big of a dehiscence, because probably a bigger dehiscence would potentially have more of a response, and so standardization of that might be a little bit challenging. But yeah, sure, on a CT scan, if you see a big dehiscence and you do the VHIT in that direction, probably you would expect something different just because it's like stretching against the membrane. Of course, you could do the ocular cervical VEMP to confirm, but that's a very good point you bring up. Okay, thank you.